I'm really excited to start this session, leading the way for all of our pain organizations. We have folks from North America, local, our different provinces, and the world. So I would like to introduce my co-moderator today, Dr. John Pereira, and I'll take a couple moments to do that, and we're just going to step right on in. So Dr. Pereira is the president-elect of the Canadian Pain Society, immediate past president of the Pain Society of Alberta, and was a founding co-chair of the Alberta Pain Strategy. He is a past Ronald Melzack Fellow of the McGill Pain Center. He has spoken on the topic of chronic pain both nationally and internationally, including at the Mayo Clinic and Centers for Disease Control in Atlanta. He represented Western Canada on the Committee of Physicians who wrote our country's national guidelines for the diagnosis and treatment of fibromyalgia. Dr. Pereira was the physician lead of the team that won the very first Health Quality Council of Alberta Patient Experience Award in the field of pain management. So looking forward to co-moderating with you today with our distinguished panel, having a very good conversation, learning more about what's going on. And I'm just going to pass the baton on to you, Dr. Pereira.
Thank you so much for that wonderful introduction. On behalf of 𝐒𝐿, the chair of this World Pain Summit and Secretary General of the Pain Society of Alberta, welcome. The next hour is entitled Leading the Way, Provincial, National, and International Pain Advocacy. Simply put, you spoke and we listened. Last year, these same panelists spoke and generated so many rave reviews, we just had to have them back again this year. And I'm delighted that my co-chair for this event is 𝐒𝐿 herself. Thank you, 𝐒𝐿, for everything that you've done for this summit and for the Pain Society of Alberta. As this is the annual conference of the Pain Society of Alberta, we will begin today in that province. And it is my honor to make these introductions. Tracy Wasylak is the Chief Program Officer of the Strategic Clinical Networks with Alberta Health Services. She has held numerous leadership roles within AHS. She holds an adjunct assistant professor appointment with the Faculty of Nursing at the University of Calgary. She's the co-lead for the Learning Health System platform and has received the Order of Merit Nursing Policy Award from the Canadian Nurses Association in 2018. She was the recipient of the AHS President's Excellence Award in the category of Innovation. And in 2019, she received the Award of Outstanding Achievement in Quality Improvement for her provincial contributions to care pathways. And if I may just say, we would not have an Alberta pain strategy if it were not for Tracy Wasylak. I would also like to introduce Dr. Rob Tanguay. Dr. Tanguay is a psychiatrist who completed 2 fellowships, one in addictions medicine and one in pain medicine. He's a clinical assistant professor with the departments of psychiatry and surgery at the Cummings School of Medicine at the University of Calgary. Academically, he's involved in research involving trauma, addiction, chronic pain, opioids, cannabis, and psychedelics, and is a member of the Hotchkiss Brain Institute and the Matheson Center for Mental Health Research and Education. Most recently, Dr. Tanguay helped found and is the Chief Medical Officer of the Newly Institute, a program dedicated to providing medical and psychological intervention for people living with complex and treatment-resistant mental health disorders, such as PTSD, depression, anxiety, addiction, and chronic pain, including access to psychedelic-assisted psychotherapy. Rob is the president of the Pain Society of Alberta and co-chair of the Alberta Pain Strategy with Tracy. And again, on a personal note, every time I introduce Rob, I always tell him he's in the wrong room, because there's an adage in business which says, if you're the smartest person in the room, you're in the wrong room. And so often he is that person. And although he was my student once upon a time, I have learned so much from him. And so we will begin with the first question, which will go to Alberta, and then I will introduce some of the other panelists. And to Alberta, Tracy and Rob, Alberta has received a CIHR Health System Impact postdoctoral fellowship, which is very exciting. And that started last month. Tell us about some of the very exciting work they will be doing for the next couple of years.
Thanks,
I'll pass
John.
this over to Tracy. Yeah.
Yeah. So thank you very much. We're really excited about it. For those of you that may not be aware, the fellowship program is a national program. And you, as a host organization, you have to, in the fellowship, have both an academic supervisor and a health system supervisor. And the whole goal of the experience is to give postdoctoral fellows an expanded opportunity to build competencies outside of their traditional academic world. So for us, Dr. Elena Lopentina is our fellow, and she is going to be working with us. You heard Verna talk about how chronic pain is a priority in our province. And so we have been thinking about, well, what would a model of care look like to be able to understand how can we organize our scarce resources in a way that can maximize the capabilities of treating patients in a stepped care model. So we, our fellow is going to be looking at that model of care. And just a quick sidebar shout out to CADA and the other provinces that may be on this call, because CADA did a review of chronic pain models, and we got it prioritized to the top of the list because all the provinces in Alberta said, yeah, that would be a good review. It would be good for all of us to understand, are there better models of care that we should be adopting or adapting based on lived experience? So Elena is going to be taking that step care model we have looked at, and she will be building out a bit of an economic analysis of what would a step care model look like. What would be the return on investment to think about the interventions within the model, and then also do an analysis of opportunity costs lost if we don't implement the model. And our rationale for doing that is really twofold. One, sometimes when you go to the funder and you ask for incremental funding, you say, well, this would be the greatest thing since sliced bread. But that's great, but if money's tight and decisions have to be made about scarce resource investment, understanding what the cost would be without the new model is probably a critical benefit to somebody who has to make those funding decisions. So we believe if we can do a comprehensive economic review of the opportunity, what the outcomes and improvements would look like, and what would be lost if we didn't go in this direction, we feel that we have a better chance of convincing the funders and people who deliver services that we need to start shifting our model here in Alberta. And so Alina's expertise, she's already done models of care work in arthritis, and she's got a fantastic supervisor who's a health economist. And so backed by the chronic pain working group, models of care working group that got established, which has some unbelievably talented people at it, we think we're going to be able to produce something that not only will help us here in Alberta, but it could have application to other provinces and maybe other countries. So sorry, John, I probably went, you can tell I'm all passionate about it and probably went on too long, but Rob, what did I miss?
I don't think you missed anything, but you know, the advantage that we have in Alberta is our incredible primary care networks, our already functioning pain programs, and some of those networks actually having programs themselves, allowing an already step program there and trying to figure out now how do we integrate that all together. Really an exciting opportunity considering a centralized healthcare system with incredible primary care facilities to develop a pathway that makes sense to each and every individual who is living with pain. So it's going to be very exciting to see how this comes out. And of course, my advantage of working with Tracy is I get to also always be thinking about the health economics and sustainability in a healthcare system. So that's an important piece that we're bringing in. So I have nothing more to add to what she already mentioned. And I think this is going to be a really excellent outcome of what we've got.
Thank you so much. And we will come back to hear more about the exciting things happening in Alberta shortly. For everyone watching, remember, if you have questions, please send them in, and Christelle will do her very best to make sure we get as many questions answered for you as possible. We now move just slightly to the east of Saskatchewan. Dr. Susan Tupper is the strategy consultant for pain quality improvement for the Saskatchewan Health Authority. She's a licensed physical therapist with a PhD in community health and epidemiology and a postdoctoral fellowship in pediatrics. Susan's role with the Health Authority includes applied research, program planning, clinical standard writing, education for healthcare providers, trainees, and the public. Her research examines clinical interactions about pain for those with chronic health conditions, virtual reality for pain management, and education about pain for exercise instructors and family caregivers. Susan's the chair of the board of directors of the Saskatchewan Pain Society, 𝐒𝐂𝐂𝐑𝐈𝐁𝐄, a non-profit charity that aims to improve pain management. And on a personal level, I met with 𝐒𝐂𝐂𝐑𝐈𝐁𝐄 several years ago. And when you think about a tightly knit, high-performance team, a small group that is doing great things, you think 𝐒𝐂𝐂𝐑𝐈𝐁𝐄. And so I asked the question to you, Susan. The project Improving Pain in Saskatchewan has interviewed over 150 people and identified over 60 change strategies. Please tell us about this project, and is it the start of a provincial pain strategy in Saskatchewan?
Well, thanks so much, John. That's a very kind introduction. And I agree with your assessment of our 𝐒𝐂𝐂𝐑𝐈𝐁 Pain board members, that we are a hardworking group of volunteers. So very grateful for my my co-members of the board. So yes, Improving Pain in Saskatchewan is a project that has been in the works probably since about 2018. So myself and my co-chair of the board of 𝐒𝐂𝐂𝐑𝐈𝐁, Glenn Mary Christopher, at the time, we met with the leadership team of the Saskatchewan Health Authority, which was just transitioning from a regional health authority division of 12 different health authorities, or health regions rather, into a single health authority. So we met with the executive leadership team and talked about 𝐒𝐂𝐂𝐑𝐈𝐁 and talked about the issues related to pain, and asked for their guidance and in creating a provincial pain strategy to build on the work that 𝐒𝐂𝐂𝐑𝐈𝐁 had already been doing. And got some great advice from them. Similar to Alberta, Saskatchewan did also divide themselves into health networks. And so we designed a research project, and we're fortunate enough to receive funding from the Saskatchewan Health Research Foundation and Saskatchewan Centre for Patient-Oriented Research for a 2-year project to explore kind of a needs assessment, but also moving into action. So our project is a community-based participatory action research project. And of course, we got our funding for this community-based project in March of 2020. So we had to change our methods a little bit. And instead of going into communities and working with community-based organizations and collecting data face-to-face, we had to move largely to a virtual approach to engaging with people. But yes, 152 interviews. The nice thing about the way that we did our research is that we got 152 in-depth interviews. So we met with people. Some of the interviews were only 20 minutes long, others were 90 minutes long. Over half of our interviews were with people with lived experience who live with pain, or their family members. And we worked with 3 health networks in 3 communities: Saskatoon's downtown core neighborhoods, in Yorkton, more of a rural community, and in Regina, we focused on pediatrics. And from these interviews with people with lived experience, we also interviewed healthcare providers of a variety of disciplines, both within the health authority as well as private practitioners. And we interviewed health services decision makers and representatives from community-based organizations. And we heard a lot of really phenomenal information about the needs for pain management in this province. And so one of the underlying threads that really came through, despite these 3 communities being quite different, was the need to address stigma around pain, mental health, and substance use in our province. And so we're now moving towards our phase 2 and 3 activities, where we are designing and implementing activities and interventions based on the working groups in the 3 communities. So very patient-oriented approach to this project. And our phase 4 work is actually designing a provincial pain strategy. So what we're doing now is getting feedback on the data from decision makers and physician leaders in the province, and hearing from them about the next steps, how to make this work sustainable and keep it going ongoing beyond the term of our research project. So we're really excited about the projects that are going on, and if there's time, I'll tell you more about those, but I'll pass the baton on to the next person.
Thank you so much, and I think you have every reason to be excited. That is exciting. We now move west to beautiful British Columbia. Maria Hudspith is the inaugural Executive Director of Pain BC, a collaborative nonprofit organization that works to enhance the well-being of people who live with pain through empowerment, care, education, and innovation. In 2019, Maria was appointed by Health Canada as the co-chair of the Canadian Pain Task Force and co-authored the National Action Plan for Pain in Canada, released by the federal government this spring. Maria is one of the co-principal investigators in the CIHR-funded National Pain Research Network, also referred to as the Chronic Pain Network, and a partner in several author research endeavors, with a focus on engagement and co-leadership of people with lived experience. To this work, Maria brings more than 2 decades of policy advocacy, community development, and organizational change at the nexus of health equity and social justice. And if I may just say, every time I have a question, because I don't know what to do, I am often calling Maria, and she always knows what to do, which is fantastic. And I appreciate her guidance. And so the question to Maria and BC has continued to refine and polish a laddered model for building skills, knowledge, and confidence among providers through a new adaptive mentoring network for pain. Please tell us about this new program.
Can you hear me now? Great. Okay. So thanks so much for that, John. And I think there are many times where you've called me and I haven't known what to do. So I think you're putting some polish on it, but I appreciate it. Many people are familiar with Pain BC's clinical education programs. Over the last number of years, we've been building this, what we call a laddered model, which is really akin to the stepped care model for people who live with pain getting health services. It's a stepped care way of building clinical capacity to assess and treat pain. So we started out a number of years ago developing discipline-specific workshops and holding an interdisciplinary conference. Many people told us, you know, we need something foundational. Let's do kind of Pain 101. And we created something called Pain Foundations, which is an online model that's suitable for all healthcare providers. It's actually a course with about 5 modules, and it's really the entry into Pain 101. From there, we created this next level, which are discipline-specific workshops for a variety of different healthcare disciplines where people can work with advanced practice leaders and go really deep into best practices for their specific discipline. We then took on creating 𝐒𝐂, Project 𝐒𝐂, which many people are familiar with, and this is this video-based case-based mentoring that happens with a hub and spoke kind of model. What we found is that people still want more, and people want something that's more flexible, very adaptive, and also something that doesn't just talk about pain, but really looks at building capacity around the nexus of pain, substance use, and mental health. So we are a partner with the Centre for Effective Practice in Ontario and the Atlantic Mentorship Network in Pain and Addictions in a new program that's been funded by the Substance Use and Addictions Program at Health Canada. And this is an adaptive mentorship network. The idea here is that it's interdisciplinary, so family physicians, nurses, physios, and many others, and that the mentoring can be any way. It can be synchronous or asynchronous. There are small group as well as individual kind of models. And their intention is not just to build clinical capacity, but to actually create a supportive, collegial, and compassionate community. We know that so many clinicians working with people who live with pain, substance use, and mental health issues really suffer with burnout, with incredible stress. And so this is also a way to address those kinds of issues. So the program's just getting up and running. We've just recruited our medical co-directors, and we're in the process of recruiting mentors. So I'm very excited about this, and it will become yet another option in this laddered kind of continuum to help clinicians serve people who live with pain better. Thank you.
Thank you so much, Maria, for all that you're doing. We now move on the national level, first for Canada, to the Canadian Pain Task Force. Dr. Fiona Campbell is a professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto. She's director of the Chronic Pain Program in the Department of Anesthesia and Pain Medicine and co-director of the Sick Kids Pain Centre at the Hospital for Sick Children. Fiona is past president of the Canadian Pain Society and co-chair of Health Canada's Canadian Pain Task Force, along with Maria, which has recently published an action plan for pain in Canada. And if I may just say, it is not easy to bring together 7 million people with pain, thousands of clinicians across the country. And Fiona has that magical, eloquent ability of finding that middle ground that we can all agree upon, something I need to learn. And so I ask you, Fiona, the final report of the Canadian Pain Task Force, Action Plan for Pain in Canada, focused on 6 primary goals. One of them was improve access to timely, equitable, patient-centered pain care. And we can all agree that is incredibly important. What are some of the ways we can achieve this goal, in your opinion?
Thank you so much, John. I so enjoy your hyperbolic introductions. We need to begin with the premise that we will never have capacity in specialty care to see the 8 million people living with pain in Canada, and neither should we. We need to build capacity in the community, particularly in primary care. And I love the work that Cadith and Alberta are doing in this regard that Tracy mentioned earlier. We really need to develop patient-centered care models, including stepped care frameworks, which adapt services based on the needs of the people living with pain. So you might begin with education and self-management, even before that, prevention, but education, self-management, peer support networks, hub and spoke models of care, virtual care. COVID catapulted us into virtual care, which was amazing. Stuff doesn't usually change so quickly in healthcare, but we need to be mindful that this is not a panacea and is currently under close scrutiny. Nothing fully replaces in-person care. We must go with patient preferences, and ultimately flexible hybrid models are likely going to be the way to go once you get into specialty and tertiary care. Interprofessional teams must incorporate different clinical approaches and specialties, and we need innovative models that are focused on rapid access to pain care and early intervention. We need common, centralized, and clear referral pathways that integrate services and also improve navigation of care. We hear this a lot in chronic disease models, like patient navigation is something that is so desperately needed. And we need to develop education for people living with pain, their families, and health professionals. So I'm going to stop there because I know that this is all top of mind for all the people on the panel, and others may well have things to contribute in discussions. So I will hand it back to you, John. Thank you so much.
Thank you. And yes, we will be having some discussions among the panel members in just a moment. We now move to America. Dr. Michael Gold is presently a professor in the Department of Neurobiology at the University of Pittsburgh School of Medicine. He earned his PhD in neuroscience at the University of California, Los Angeles, under the mentorship of Dr. John 𝐒𝐂𝐑𝐈𝐁𝐄, and received postdoctoral training in neuropharmacology and biophysics at UCSF and Los Angeles under the mentorship of Dr. John Levine and Anna Maria Curia, respectively. Dr. Gold began his academic career at the University of Maryland, Baltimore in 1998 under the chairmanship of Ron Dubner. In 2006, he was recruited to Pittsburgh by Dr. Jerry Gebert, where he ran a lab focused on peripheral mechanisms of pain. His research in this field is focused on the identification of factors, most commonly voltage calcium channels and ligand-gated ion channels, that enable sensory neurons to contribute to persistent pain. He serves on the editorial board of the Journal of Pain, the Journal of Pain Research, and the Neurobiology of Pain. Dr. Gold, served on the scientific program committee for the Society for Neuroscience, the American Pain Society, and the International Association for the Study of Pain. He was elected to the Council of IASP in 2012 and served as the IASP liaison to the American Pain Society Board. Dr. Gold is currently president of the U.S. Association for the Study of Pain. I just want to say, everyone here in Canada and beyond is very excited to see the growth of USASP. This titan has grown and grown, and we're very excited that they're going to have their first in-person conference next year, so watch for that. And so I asked Dr. Gold, the USASP has a special focus on answering the following question: how to best engage patients and patient advocacy organizations. Tell us more about this important task, especially for a country as large as America.
Thanks, John. It's not an easy question to ask. It's always inspiring to hear what you guys are doing up north, really across the country. And the integration of your societies, your meetings, basically all educational efforts I'm a basic scientist, clearly per the pedigree you just read, that the integration, even at the basic science level of patients, has really, I think Canada has really set the mold for that, and the rest of the world has been following on. And so we down here are really trying to follow suit. And in the USASP, appreciate that it's a critical component of what we want to do. Our mission is to better the lives of those suffering from pain. And so to help accomplish that mission most effectively, the key is really going to be to engage patients and patient advocates. At present, we're really just taking a two-pronged approach. And that's that we have a committee structure, a number of committees within the USASP. One of them is Coalition Building and Advocacy. The chairs of that committee are Diane Hoffman and Lindsay Yesick, both of whom have had a long track record in working in the patient advocacy domain, and are really spearheading those efforts from a committee level, with recommendations to the rest of the committees across the USASP, as well as the USASP board, for pathways moving forward to have patient advocates and or patients involved in board meetings, part of our scientific program committee, et cetera, et cetera. As you said, we have our first in-person meeting. We hope will be in person, coming in May of 2022, and so that planning is just ongoing now. And so folding in a patient advocate component is going to be key. The second part of that is we have a number of special interest groups. The special interest group that engages the patient advocacy side is the clinical care and advocacy, and Gary Walco is the president of that SIG, and he has a certainly long track record of experience working in the domain of how to get patients access to really the full spectrum of pain management approaches in the US. And so the two of them, the committee and the SIG working together, are really our initial forays into this domain, with people positioned in both of those that really are going to be serving as the interface as we move forward.
Thank you so much for that. We now move to Australia. Carol Bennett has been the CEO of Pain Australia for 4 years, leading the development of Australia's National Strategic Action Plan for Pain Management, which has now been endorsed by all Australian governments. Over the last 2 decades, Carol has worked at senior executive levels in national health and aged care organizations, and has served on national and international boards and advisory groups. Carol has been National CEO of Alzheimer's Australia, Consumers Health Forum of Australia, Rural Health Workforce Australia, and the Victorian Alcohol and Drug Association. I just want to particularly extend a real thank you on behalf of all of us for everything that she has done. She always wakes up really early in the morning, Australia time, to give advice, whether it's the Alberta Pain Strategy, to join our conferences and so on. And it is really early in the morning right now in Australia. So thank you so much for that extra effort. And here's my question to you. Pain Australia is still involved in advocacy to see more multidisciplinary care rolled out to accommodate recent regulatory restrictions applied to opioids and the implementation of a national real-time monitoring system. Tell us about these changes and how they are changing pain care in Australia.
Well, thank you, John. And I must say it's a great pleasure to be here again this year, and to hear Fiona and Maria, Susan, Tracy, Rob, all speaking about the amazing work that is happening in Canada. It's always so impressive, and we have a lot to learn from what you're doing in Canada. And similarly, Michael, it's great to see the US looking at those patient engagement models. So thank you so much for having me here. I guess, as you said, John, we are very involved in advocacy at the moment around the National Action Plan, which has now been endorsed by all Australian governments. And I guess a lot of the focus in Australia in recent times has come about because of the escalating situation with harms, overdoses, hospitalizations related to opioids. And I mean, somewhat ironically, that has created a bit of a lightning rod for more of a focus on chronic pain. So it has been a vehicle for creating options that look at, raise awareness about chronic pain, but also look at how we can, better deliver quality services, better awareness, better management with and for consumers living with chronic pain. I mean, the reality is that medication remains the mainstay of treatment for chronic pain in Australia. It is the most affordable, it is the most accessible treatment. I mean, obviously it's recommended as part of a holistic approach to chronic pain management and not necessarily for longer term use, but it is still a very important part of management. And the National Medicines Policy is currently being reviewed in Australia. We're very involved in that. But certainly when some of the restrictions were introduced last year, and I think when I spoke in this conference last year, there were some significant issues for patients, for consumers around forced tapering when those restrictions were introduced. And that caused quite a bit of concern and distress for many, many people. And that is why we're so keen to see more multidisciplinary approaches put into place. I mean, it's, we understand and we support the moves to reducing harm related to opioid use, but we need to balance that to ensure that we still see continued access, we still see safe and effective use of opioid and other medications as an important part of the treatment regime for consumers. It is, and we have been working with the states of Australia, the jurisdictions of Australia, around the implementation of the National Action Plan, because many of them, obviously, like your structure in Canada, are delivering services on the ground. One of the major rollouts has been the National Real-Time Prescription Monitoring Scheme, and I know that you have those schemes already in place. It's now being put into place in Australia. For us, it's been an opportunity to work with those jurisdictional governments to try and use it as an opportunity for conversations between patients, dispensers and consumers, and raise more awareness of chronic pain and better management. So that's the ideal. We are working with consumers. We are working with health professionals as well around the messaging for that program to ensure that it is positive, that it is about delivering better care. And we're in the early stages of that. It's about to be rolled out in some jurisdictions, the biggest one, New South Wales. It has been rolled out elsewhere. So there is an opportunity, but we need to capture that. So that's where we're at the moment, John.
Fantastic. Thank you so much. Now that you've heard from each of the panelists, please do send in your questions. As it so happens, some questions have already come in. So I'm going to pass now to Christelle, and she will direct some questions from our audience to our panel.
Thank you. This has been very engaging. We have about 25 minutes left, so I definitely would love to ask a question to all of you. Maybe we can keep it simple by using the raise hand feature, or everyone can be kind and considerate and ask and answer the question. So I'd like to start us off with the first one. Namely, we're entrenched in COVID at times, and it's been quite sporadic over the last 18 months. So do you, in your different areas of practice, expect an explosion of persistent pain post-COVID? And how might you prevent or avoid going backwards in our pain management strategies? So who would like to start off?
I'll try. I mean, I'm sorry, if Maria, I'll happily hand it over to Maria as well. But I mean, this is a humble opinion because there is no real answer to this. In my humble opinion, what we're going to see is the outcome of COVID being this massive influx in mental health disorders that we're seeing, and that those people who are struggling with pain and see an influx in mental health disorders, we're going to see an influx of those individuals coming for help. Understanding that 7 million or even more Canadians and around the world, that number goes into the billions of people who struggle with pain, it's impossible for our system to treat everyone. But often what we end up doing is treating a lot of people who struggle to cope with their pain and struggle with a lot of mental health with the pain. And if we see this massive influx in mental health, we will likely see an influx in people struggling with pain requiring supports and treatment. That would be my guesstimation, but that's all that is. I'll pass it on.
Thanks, Rob. Yeah, I agree. I think this is one of the things that we highlighted in the National Action Plan, is that with COVID, we've seen the shuttering of many of the things that people who live with pain use to live well with pain, whether those are physical therapy offices, community rehabilitation kinds of programs, even just the things that enable people to break social isolation and be connected in their communities, which manages stress, which reduces the negative impacts of pain. So I think, we have the impacts of the public health orders that have been there, the isolation, the lack of access to services. We have increased use of medication and also other substances that people have been using to manage pain. We have delayed surgeries, which has all kinds of impact for people in terms of exacerbating pain. And then we have this other problem that I think we've really yet to understand, which is the impact of longstanding pain resulting from long COVID. So even though so much of what governments are reporting on are the number of people who have recovered from COVID, what we know is that there are significant numbers of people who have recovered from that immediate bout of illness, but who have long-standing symptoms, and many of those people are talking about chronic pain as a result. So I think that is something that we have yet to truly grapple with or quantify. We're seeing the start of the launch of these new long COVID clinics in the provinces, but even those, we're starting to see wait lists and real challenges with capacity, and I think that's truly going to get worse. So I think, yes, we're going to see more pain, and I think we're going to see pain from things that we didn't fully grapple with before, like long COVID. Fiona.
Oh, thanks. Actually, I was going to mention many of the things that you did as well, Maria, which is hardly surprising given our close working relationship. But I did just want to emphasize that it's not just the indirect impact on the mental health and lack of access to care, but really changes in the neurobiology from long COVID. So just the biology will change. And so we will have new chronic pain. I don't know about an explosion. I think it's too early to tell. Thank you.
Sure, I'd love to hear from Dr. Gold, and maybe we'll have time for another question. So thank you.
I was just going to add the 2 cents that, at least from the preclinical world, what we see is the impact of early life stress. And of course, we've seen that in the clinical domain as well on the incidence of pain syndromes. And so I think what we may also be seeing, and it's going to be much harder to prepare for, is the impact of COVID and the stresses it's had on really this generation of kids that have grown up under it, 10, 15, 20 years down the road.
And absolutely, go ahead, Susan. I'm sorry, I didn't see your hand up. So please.
Yeah, no worries. No, I was just going to add that there's 2 populations that I'm particularly concerned about. Number one is our healthcare providers, our direct healthcare providers who are working nonstop and are experiencing a lot of secondary trauma through providing care to families and patients who are suffering quite acutely. The other group that I'm quite concerned about is older adults who are residents of long-term care homes and their family caregivers. And this is a population that already lives with a lot of chronic pain, but we've seen the impacts even in homes where they managed to keep COVID out. And they didn't have COVID outbreaks, but there was excessive loss of life and increases in depression and reductions in functional abilities just because of the loss of some of the services. People weren't able to move around as much. There was more, I guess, restrictions of mobility, less psychosocial supports. So those are 2 populations that I'm watchful for what might happen, and the family caregivers for people with dementia whose loved ones did pass away from COVID or just when they weren't able to visit, and there's going to be a lot of poor bereavement or challenging, difficult bereavement, I think, that might impact pain in the future.
Sure, go ahead, Carol.
Yeah, look, I just had a question for others on the panel, and I mean, having just come out of lockdown, I appreciate everything everyone's saying, and we're probably at an earlier stage than you are, but I'd be really interested to know to what extent your countries are planning for long COVID, and is there a proactive approach to that? And, you know, should we be looking to do that now? And that's certainly where we want to go, but, you know, are there active strategies in place? Is there, you know, a concern about how to address this in the future, and is it being proactively managed?
So it's Tracy. I wonder if I could just jump in, Carol, and say that in Alberta, we absolutely have been trying to get ahead of this. And just kind of 3 or 4 strategies that may be useful. One was we did start a rehab advice line, because in a lot of people in post-COVID, it's a rehabilitation need. I mean, obviously there are pulmonary pieces, but rehab. And so we hooked onto our HealthLink line, specifically a rehab advice line, to be able to, I'm just going to take my video off, to be able to have the consumers phone in with symptoms and then have our OTs and PTs try and match up. We've started the long COVID clinics. We've taken a north-south, northern Alberta, southern Alberta, with a hub and spoke, because we know we can't get everyone into a specialty clinic. Our government has also given us some research grants. So our neural rehab vision, SCN, has been given funding to actually follow up, do a follow-up survey on all COVID positive patients. So through our provincial database, we've sent this survey out to, in the short and medium term, evaluate where people are at, so we can get a better handle on what are the underlying issues that people are still faced with. And I do know in a couple of our clinical populations where we've seen deleterious effects, we've been deploying home monitoring, pulse oximetry, particularly pregnant women, and then other patient populations where there's big risk. So this is the beginning, I think, of our strategy to try and get a handle on what we're going to be faced with a little bit more longitudinally. That's been our approach. Rob, you may have more to add there.
You know, I think, you know, trying to take a strong addiction and mental health strategy, as well as education, even our healthcare providers being educated on what long COVID is, as that's a major piece. There's no point in trying to say we're going to treat long COVID if nobody knows what it is. And so that's a big part of it. And obviously seeing some of the research coming out of U of A and U of C looking at this stuff will be really important to try to understand. And of course, as mentioned by Tracy, the survey to all of our post-COVID patients across the province, understanding what are the symptoms that they're struggling with and trying to actually get some epidemiology and true data behind it. Because right now it's a pretty big hodgepodge where we sit. So it's a big piece of what we're trying to do is really understand from a data point so that we can educate and move forward into the treatment point, rather than just kind of jumping into doing something quickly that we don't quite understand.
Thanks, everyone. It goes to show that regardless of where we're at, there's very key and consistent messaging that we're all experiencing, and it's so good to learn from each other. In the interest of time, I know we have about 15 minutes left. I'd like to kindly pass it back to Dr. Pereira, and we can continue these fruitful conversations.
Thank you, Christelle. As mentioned, this is a fantastic conversation. Let us merge 2 questions together and present it to the panel. On the panel, we've got researchers, we've got clinicians, we've got clinician scientists, and the same is true in our audience. And so, to the researchers, if you could have one basic science question answered in the field of pain management and the results were on your desk tomorrow morning, what would that basic science question be as it relates to pain? And to the clinicians in the audience, if you could have any one randomized controlled trial in the field of pain management and the results were on your desk tomorrow morning, what would that clinical question you want answered to be? Let's open it up to our panel. Okay, I'll start with Dr. Gold.
Well, I certainly couldn't have answered Carol's question because, of course, the issue of COVID is so politicized down here that the response to long COVID, I shudder at how that would be handled. In response to John's question, from my perspective, the issue or the big question that we're really facing is how do you identify underlying mechanism? Whether it's through questionnaire, whether it's through QST, through a whole host of strategies. From my perspective, they're all blunt instruments. And what we need as a biomarker or combination of biomarkers or algorithm based on the data generated from all those endpoints is to be able to identify what's going on. As you know from the German Pain Network, when they classify patient phenotypes based on the QST response, they can get a population that is defined as having pain driven by the irritable nociceptor. Well, for my own work, I could describe 7 different mechanisms that would lead to an irritable nociceptor. So from a clinical perspective, treating an irritable nociceptor is not going to be an easy thing to do. We need much better precision in terms of what we can do from the biomarkers. And I think it's going to be a combination of algorithms that weave together the various assessment tools that we have available.
Thank you so much. Now we go. We've waved our magic wand to answer that question. Now to Fiona. What would you like answered?
Thanks, John. Yes, this is hugely complex, many contributory factors to pain, but preventing pain is a patient priority. So I would want to know about effective treatment interventions for one of the known risk factors for getting chronic pain after surgery in kids. So for example, a trial to evaluate the effectiveness of a pediatric self-management intervention for anxiety or parent catastrophizing, or one of the things that we know influences and increases the risk of chronic pain after surgery in children. So yeah, treatments for known risk factors to prevent getting chronic pain. Thank you.
Thank you. Susan.
Well, Michael and Fiona both asked brilliant questions, and I would like those answers too, please. But my question is more along the lines of an implementation science question. So what I would love to know is in Saskatchewan, we're about to publish a clinical standard, broad across the lifespan clinical standard for pain assessment and management. And what I would love to know is what the barriers and facilitators are to the different elements of that in each clinical setting, everywhere across the entire health authority, across the lifespan, in all points of access to care. So I would like to know what supports are needed to help move this clinical standard into practice, and what barriers we need to work around.
Fantastic. We are now less than 10 minutes from the end. Time has just flown by. And so therefore, I want to go back to each of our panelists and ask them for their respective organizations, what's next? For your organization, are there upcoming meetings, conferences, seminars, particular endeavors, projects, and strategies? We will close on that question. We'll begin with Alberta. What is next?
Well, I mean, I can jump on this to start with. I think that we have a lot of projects underway. A Can Health project looking at technology in transitional pain services. We have several grants in right now that we would love to get approved. So that would also help in direction as to where we're going. Looking at the possibility of what a provincial pain protocol and program would look like. You know, one of the things that I really think is going to be important is what is next is We have a lot of projects underway, and it's going to be exciting to see a lot of those projects come to fruition. And looking at supporting national or provincial transitional pain services, provincial pain programming, virtual pain programming, really focusing on access and supports and eliminating those barriers of health inequity based on both income and location across the province. I think those will be important, and I'm sure I've missed some other things, and I'll pass it to Tracy.
Just say one thing, we wrote a memorandum of understanding that got signed off with primary care, the colleges, AHS, about how we would support chronic pain patients in their opioid management and approach. And what's next is we're actually meeting with all those groups to outline a clear action plan as to and accountabilities, and we're going to monitor it. And I'm excited about that because it's not a memorandum sitting on a shelf. Thank you.
Thank you. And now, what is next for Sask Pain?
Thanks, John. So with the Improving Pain in Saskatchewan project, we have a list of 61 things that we've been asked to do. So we're working towards that, and we've already got some projects on the go. One of them is a bi-monthly webinar that we call Partners in Pain. So this is a 1-hour session that we have a brief education session from a healthcare provider, a story from somebody who lives with pain, and then a facilitated activity where people can try things like art therapy or relaxation techniques. So that's happening now and on the go. And we also have a new podcast that we just started, and a great board member, Alexander Pavlich, who's working on releasing that. Again, a lot of patient stories and hearing from Saskatchewan-based healthcare providers. So with these projects, we're trying to raise awareness, both bring community engagement, but also raise awareness of the existing resources that we have for pain management in the province and things that you may not necessarily have thought of as being pain management activities. So we're raising the awareness with that. And then one of the other key strategies, again, we have lots of research grants going in right now, and hoping to get some funding for next projects with addressing stigma and education of healthcare providers and patients around stigma experiences that are common for people with pain in healthcare contexts.
Thank you so much. And now we turn to what is on the horizon for Pain BC.
Thanks, John. I think there are a few buckets of things. So one of the buckets is continued development of new projects. So we're working with the Toronto Academic Pain Medicine Institute and the Transitional Pain Clinic in Toronto, and AHS is sort of at the edge of the table on that one, keen to be involved. So we're really looking to create a new patient education program geared towards people going into surgery. So this would be something trying to get at this issue of acute to chronic transition and just improving outcomes for people having surgery. So that is just getting underway. We have new projects that are in their first phases of deployment, like the Adaptive Mentorship Network. And then we have the scaling of some of our existing programs. So some of our programs have been running over the last couple of years. We are getting calls for those outside of the province and figuring out ways to expand the reach of those. We're also getting calls to tailor those programs for different populations. So we're experimenting currently with cultural tailoring of programs, so tailoring in collaboration with Indigenous knowledge keepers and elders. We're doing some work with trans and non-binary youth who have very high rates of chronic pain, so tailoring programs there. And then in 2022, hoping to be doing not just cultural tailoring, but actual translation of some of our self-management programs for a variety of different linguistic groups. So that's what's on the horizon for us.
Thank you so much. Canadian Pain Task Force.
Thanks, John. As you know, the task force has 150 recommendations in key areas. What people may not know is that after a government receives formal recommendations from a task force, it has to develop a management response plan. We're kind of in a holding pattern because the government has not been reformed yet, but bureaucrats will need to look at each recommendation and develop a plan for who is doing what and how, including identifying actions that are outside of government mandate, but in scope for pan-Canadian health organizations and others, such as people on this call. Having said that, we already have some deliverables. We were able to influence $116 million of new SUAP funding dedicated for pain. The task force secretariat is co-hosting a roundtable with CADIF next week for provinces and territories on models of care so we can reduce the variability of how we do things across Canada. And something for you as individuals, there is an excellent campaign at www.paincanada.ca with ideas of what you can do to move things forward, including templated letters to canvass your MPs to get pain on the health minister's mandate letter. So if everyone at this conference wrote to their MPs and they created noise in government, if we can get pain mentioned on the mandate letter, it will give us great leverage to implement our recommendations. Thank you.
Thank you so much. And what is next for the USASP?
We've got a lot going on. Certainly, as I said, planning for our 2022 Scientific Program Committee. We've got an election coming up. We've got each of the committees has a mandate. Most immediately, and one of the major focuses of the organization is ensuring the next generation of pain scientists have a home and a supportive network. And so a lot of our programming is directed towards them. So we're running a monthly virtual series directed at early career scholars. The one is next week. It's how to get your research published with Mark Jensen, the current editor-in-chief of the Journal of Pain. And we'll be running one of those each month, at least until the meeting.
Thank you so much. And finally, Pain Australia.
Thanks, John. Well, we have a federal election looming either later this year or early next year. What Fiona said about a mandate letter certainly resonates with us. We will be focused on advocacy. And one of the things that is happening here is quite a lot of focus on reviews and reform. And I think Fiona had also mentioned there's never enough capacity in the specialist area. That's certainly the case, and we're very focused on making sure that pain is an integral component of some of the broader health reviews that are currently underway, and hopefully there'll be some commitments made during the election period to reforms in the areas of national medicines policy, opioid stewardship and guidelines, prevention and primary care, National Medical Research Future Fund and the priority setting for that. We've currently got a Royal Commission into veterans and defence suicide, and that's an opportunity to highlight some of the issues around the nexus between chronic pain and for those people who might be serving in our armed forces or veterans. So there's quite a lot of activity on that policy front, and for us, the real focus in the coming months will be contributing to those broader agendas, but also defining what we really want as part of an election campaign as an opportunity to get some commitments for post the election.
Fantastic. We are out of time. Before I pass back to Christelle, the chair of the World Pain Summit, I just want to give a special thank you to Jeff Allen Productions for putting this all together, to Leah and Sylvia Vespa, who are working behind the scenes, the conference committee, and the board of directors. Thank you so very much, Christelle.
Thank you so much. And thank you to each one of you for taking the time, often in different time zones. This has become a regular, valued, and important session where we bring people together. And I know we couldn't answer all of everyone's questions, but just to let you know, session attendees here, your presenters, that there were questions along how can we together across the borders really spread pain management. And there were also questions, just something for you to think about when you go back to your respective provinces and countries and organizations. How can we, at a grassroots level, how can we continue to influence our pain education in, let's say, kindergarten, etc.? So really great questions from our attendees. Thank you so much to each one of you. It's wonderful to hear what's going on in each of your organizations. And I thank you so much for your time and attention. Bravo. So at this time, I am so pleased to pass the baton. And of course, my apologies. I want to thank Dr. Pereira too for co-moderating. He did most of the hard work. So of course, I would be remiss if I didn't say that. So thank you, Dr. Pereira, for joining us and of course, leading us very well too in that.